Good evening and welcome to the OSSA and Loader One Advanced Fitting webinar. So this evening we're going to go through the sizing and application of the unloader, but also a few little tips in terms of accessories you can use to solve some of the problems that you might face, and also just hints and tips as we go along. So just to make sure that you're getting a really good fit and the best outcome for your patient. First of all, a little bit of information about OSSA as a company. We're an Icelandic company. We're based in Reykjavik in terms of our global headquarters. There's about 3,000 employees throughout the whole of the world. We make a variety of different orthoses in terms of spinal orthoses, osteoarthritis orthoses, and knee braces. We also originated as a prosthetic company, so making things like the carbon fiber running blades that you see in the Paralympics, equally power knees, and also prosthetic hands. So the team from Touch Bionics has formed part of OSSA as well. So what I'm going to do first of all is just talk you through the webinar setup and also the team of people that we've got here to help us with this. So my name's Giles Leeming. I'm a clinical specialist orthotist based at Stockport, where we're transmitting this from. It's my colleague Peter Gill. He's the area sales manager for Yorkshire, and he's going to be the leg that we're going to fit all these braces on. And what I'm going to do now is just go over to the table, which is directly over here, and this just shows you the view that I can talk you through the application of the actual system itself. So you can see we've got a variety of different accessories here. There will be an unloader here in a moment. From there, we then go over to the fitting cam, where you can see a view of Pete, and this just means I can talk you through the fitting of the brace and also the fitting of the different accessories. If we go back to the main camera, I can also then show you another member of our team, which is Izzy. And Izzy's got a mobile camera. So from the mobile camera, we can actually highlight specific bits, and she can follow Pete as he walks around wearing the brace. And then if we go back to the main camera, it's important to mention the last two members of our team. So if you check on the Q&A part, it's on the bottom of your window. If you type any questions that you have in there, they'll be answered by our national sales manager, Stuart Hogg. So he's manning that. And equally, we have our technical monkey, which is Mike, and he is there he is. He's a bit camera shy, and he's controlling all the cameras. So if we're having any problems, change between cameras, you know that it's technical monkey difficulties. Okay, so moving on to the brace. It's a clinically proven lightweight treatment option, and we've got a bit of an agenda here. So we're going to go through an overview, a basic fitting, your normal fitting in a normal patient group, an unloader accessory overview, so some of the different accessories. You'll see all the codes and all the names in our catalogue, so it just gives us an opportunity to show you what they are and what they're used for, a little bit about troubleshooting, and then plenty of time for questions at the end. In terms of indications, the unloader is used for mild to severe unicompartmental osteoarthritis, and there's a lot of studies to support this. So originally when we developed it, we were generally thinking for Kellgren-Lawrence grade 2 and 3. However, the studies have shown that it can be effective all the way up to Kellgren-Lawrence grade 4 for osteoarthritis. It's also been significantly used in other unicompartmental knee conditions that require load reduction, and we're going to kind of work through this list as we go through. On the right, you can see a knee with unicompartmental osteoarthritis, and in this case, it's a medial one. So starting first of all with a little bit of information about microfracture. So you've got a defect in the cartilage. So when you have this situation, you can see that there is an area, a defect in that actual cartilage. So we can use microfracture treatment in order to prepare that area. So you can see it's just removing that periosteal coating over the bone. And then you can see that there's some microfracturing. So a probe is placed going through the cortical bone into the spongy bone underneath, and this encourages infiltration of stem cells from the bone marrow into form this blood clot, which is in the center of the bottom picture, and that's quite a sensitive area. And you can see on the arthroscopy picture above, you've got these areas where these punctures have been made in order to get infiltration of the stem cells into the joint. So what's important is that we protect that area, that blood clot is protected and supported, so that we don't damage it while that fibroses and forms fibrous cartilage. Moving on to other operations, we also have the osteoarticular transfer system, or OATS procedure, also known as mosaicplasty. And in these procedures, we're actually taking small donor sites of good cartilage. In a lot of cases, these are taken from the margins of the patellofemoral joint. And then these plugs, which you can see, there's a small plug of bone at the bottom. We've got a cancellous bone, the cortical bone, and then the articular cartilage on the top. And then these are then placed into the defect either side. So those plugs go into that defect, and the pink areas around it infiltrate again in the same way with microfracture treatment, infiltrate with stem cells, and then those form fibrocartilage in between those. But you can see it forms a mosaic style to cover over that defect. Next one is a MACI, or matrix autologous chondrocyte implantation. Now, this is a little bit more unusually done in the UK because of the cost, but effectively in this procedure, they're doing a small arthroscopy to take a small area of cartilage out. This is sent to a lab in Germany, where they then culture a sheet of cartilage, of your own cartilage, which can then be sutured, cut to shape, and then sutured back into the defect on either side. So you can, sorry, on one side. This is then sutured in, and then PRP, or platelet-rich plasma, is injected back into that defect, and you can see it fills this cavity in behind. So what's important is that we protect that area, potentially reduce the load from that area, because normally with a lot of these procedures, we would be changing we would be reducing the load in that area using minimal weight bearing procedures, using crutches and so forth. Just means we're reducing the load in that area through other means. Other couple of indications are tibial plateau fractures. So you can see on that picture on the left, we've got a tibial plateau fracture down there. And as long as that's stable, potentially you can conservatively manage that by load reduction using an unloader. And equally with AVN, obviously that bone can become easy to deform whilst in that necrotic stage before it revascularizes. So it's important to control the amount of load that's going through those areas. And you can do that with an unloader. Another area is high tibial osteotomies. So an unloader is often used in these instances when they want to test the methodology of reducing the load in that unicompartmental affected osteoarthritic knee. So in a high tibial osteotomy, you can see this triangle here. And what this is effectively doing, they take that triangle of bone out. So you can see before this operation is done, that knee is in a varus position. And by removing it along this line and then placing a plate and 2 screws like that, you can see that we've effectively changed the tibial varum, and we've now got a more straight leg. And the function of that is to shift the load line from a more medially directed line to moving it a bit more laterally to control that. So you can use an unloader to predict how effective that surgery will be. Okay. Also, in unicompartmental knee replacements, prior to doing the surgery and replacing that compartment, we can actually predict how effective that intervention will be by using an unloader and reducing the load in that side. So if we get good symptomatic relief, we can then progress on to doing a unicompartmental knee replacement. We're seeing a lot more patients with degenerative meniscal tears, and this is a difficult one to manage because from a surgical perspective, it's been shown that it isn't very effective to operate on these knees. So what we want is a way of reducing the load and allowing that to settle. Obviously, it is difficult for meniscal tissue to heal. So it's important to try and keep that patient active and maintain normal activity levels. Now, in terms of our goals, we're trying to reduce the pain and in so increase the activity level for the patient. The hope with this is that we're going to delay surgery and enhance their quality of life. And the studies have actually shown that it is possible to reduce the need for both over-the-counter and prescription-only medicines. The NICE guidelines for osteoarthritis from 2014 actually say that patients who have biomechanical joint pain should be considered for assessment for bracing as an adjunct to their core treatments. So it is supported by the guidelines within the UK. So this is actually taken from the NICE guidelines, and this is really the patient journey that they normally have once they go to the doctor. So we start at this initial stage. The patient goes to the doctor and is giving education and advice and information access, whether that's access to information from Arthritis Research UK. You see a lot of those leaflets and that sort of thing in GP surgeries. Also strengthening exercises, improving the strength and aerobic fitness of the patient, and also weight loss. The BMI and the weight of the patient has a significant effect on the knee. So in a lot of patients, methods of reducing their weight can have significant effects on improving the symptoms that they're feeling. When they next sort of progress, they're then going into this intermediate ring here, which gives us two different types of pain medication, but it's effectively symptomatic relief. So we've got paracetamol, we've also got topical non-steroidal anti-inflammatories, so like Ibuleave gel, ibuprofen gel, that sort of thing. From there, we then go to this final sort of ring that's around the outside, and at the top section, we have stronger pain medications. So we have opium-based drugs, intra-articular injections of steroid, capsaicin, which is actually sort of chili ointment that blocks some of the pain, and also oral non-steroidal anti-inflammatories, so ibuprofen and so on. On the right-hand side, we've got local heat and cold. So heat packs, cold packs, that sort of thing, and assistive devices, which for myself as an orthotist, I was thinking that's where I come in. But in actual fact, this is referring to Zimmer frames, walking aids, and that sort of thing. Down the bottom section, we have the surgical related interventions, so whether that's partial or total joint replacement. And then on the left hand side, we've got the interventions where we as clinicians can come in looking at different options from a bracing support point of view. So at the bottom, we have manual therapy, physiotherapy, TENS machines, shock absorbing insoles and shoes, because that's a big function of the cartilage that's been worn away as part of the osteoarthritic process. And then here we have bracing and supports. Okay, so this is the main intervention that we can use to try and support that. And again, we're using a biomechanical intervention to support a biomechanical issue. So here we have a unicompartmental knee, quite a severe one, I'll give you that, but you can see it's in a significant varus position. We've got a lot of load that's going through that medial compartment, and what we're wanting to do is reduce the load that goes through there and also shift our load line more laterally. And what the unloader is hoping to do is apply this three-point pressure system through using the frame above and below those two shells, and then the straps that go either side of the knee. We're applying a three-point pressure in order to create this force system. So by applying a valgus force to a varus knee, we're reducing the load that's in that medial compartment, but it's not necessarily about creating sort of space between that articular surface. It's about shifting that load line more laterally, but also reducing the impact that the patient is feeling at that articular surface. A lot of the patients that come to us are saying that they're getting discomfort on descending slopes, descending stairs, and these are activities where you get very high peaks of pressure in that joint. Now, there's a range of different orthoses that we have to use for different patient types. So these are all part of our osteoarthritis range. So looking on the right-hand side, we have the Rebound Dual, and this is designed to combine unloading technology using a DFS strap with ligament control. So you can see that there's a ligament brace combined with a DFS strap to give that unloading. The brace can also be adjusted here on either side to accommodate varicose valgus angulation. So you can actually adjust it according to the position of the leg. Looking to the left-hand side, we have the Unloader Lite. So this is a very cosmetic brace. It's not quite released yet, but it will be soon. So it's based around a sleeve. Very, very lightweight. So this weighs about 296 grams, designed to fit underneath clothing, be very cosmetic and very quick and easy to fit. So with this one, it can actually be washed by putting it in a washing machine. It comes with a small bag for that, and it just means that it can be washed very quickly and very easily. In the center, we then have the Rebound cartilage. So with this one, This is designed for patients who have cartilage-based lesions. So it's designed to apply the same three-point pressure system, but the major difference in which this changes is because it's applying this at a different stage throughout the gait cycle. So with a standard unloader, it's designed to apply that pressure from 20 to 25 degrees to full extension, with a rebound cartilage from 45 degrees to full extension. I'm just going to show you a little video. So this patient has a cartilage-based lesion from about 45 degrees to full extension. So looking inside the knee, you can see that there's this area a little bit further back on the condyles. So it's important to apply that pressure earlier in the gait cycle. With an osteoarthritic knee, and we have a patient here with osteoarthritis, from 25 degrees to full extension, we're wanting to apply that unloading. So you can see when we look inside the knee, that area of wear is more towards the front surface, more where we associate it with full extension, so the last 20 degrees. So you can see we use these dependent on where the lesion is located. With cartilage lesions, they're often sustained in increasing flexion as opposed to the area affected in osteoarthritis. With regards to the studies that have been done on the Unloader, it's the most researched osteoarthritis brace that's available on the market, and there's a variety of studies looking at the compliance, looking at the pain relief, and also looking at its cost effectiveness as a method to bridge and delay surgery in unicompartmental knee osteoarthritis. This is a study done in 2017, last year in Bridgend, and they did an 8-year prospective study looking at 63 patients with unicompartmental osteoarthritis, and they collected EQ5D data, and this enabled them to do a quality comparison between unloader usage in comparison to total knee replacement. Their key findings is that 39% of these patients didn't require surgery after 2 years, and it was a similar QALY gain when compared to total knee replacement at 8-year follow-up. And the QALY gains were well within the acceptable pounds per QALY threshold as accepted by NICE. So this is sort of fits in with the NICE guidelines in terms of cost effectiveness too. So we're going to go on to advanced unloader fitting and accessories. So I'm just going to move over to looking at the fitting camera. And we're just going to talk you through a standard fitting of the brace. Okay, so we've got Pete here, and we're just going to go through a standard fitting. But before we do that, we're just going to take a quick measurement of his leg. So we start with the leg straight. So in this case, we'll get you to stand up, Pete. And we're going to find mid-patella. We're placing the tape measure at the center of mid-patella, passing the tape measure down, and we want to measure at 15 centimeters below mid-patella. So we're passing the tape measure round, taking our measurement, and in the case of Pete, this comes in at about 38, okay? And then we compare this to a sizing chart and then fit the correct brace. We do have lateral versions as well as medial versions, but in this case, Pete has a medial compartment issue. Okay, we now have our brace. So our brace is in the box there. Just get rid of that one. And you can see it comes with the straps in position. And with this, let me just adjust this one quickly. You can see the straps are pretty long, so we need to make some adjustments to that before we start. So what we're going to do is get our patient in the correct position. So often you need them to slide forward a little bit and then just straighten the leg like that. Okay, so I'm just going to undo the brace either side. We're placing the frame on and into position, and what we need to do is just make sure that we've got the hinge position correctly. So one of the key areas that patients often have problems is making sure that we've got that in the correct position. Hinge position is probably the cause of sort of 80 to 90% of the problems that we might see. So really making sure that we've got this lined up level with the kneecap and halfway between the front and the back of the knee is really, really important. So ideally, if Pete was to bend his knee, you can see that it will actually stay in position and follow in line with the center of the knee like that. You straighten again, Pete. The thing to check is that we haven't got it too externally rotated, because as we bend the knee, you can see that it shifts in towards the knee like that. And equally, go straight, Pete. If we position it to internally rotated, as we flex, can you see the hinge is pushed out more medially? So we need to make sure, get it nice and straight, that we've got it in line with the axis of the knee. Okay, we're bringing the strap round either side, and you can see that we're fastening this blue on blue here. So if we just straighten your leg again, Pete, but we're going to need to go a little bit more laterally, and you can see that there's a blue marker here, like that. There's also a little shelf here, so it's really important. It's really important that we've got that in the correct position, and it's sat like that onto that strap section. Either side. Next, when we go to fasten the top, we're going to bend the knee, okay, and pass this one round. And what we're just going to do is fasten this yellow on yellow, clip that one into position, and I'm just going to tighten both these horizontal straps first of all. Okay, so you can trim these if needed, but I'm just fastening these into position. Okay, so these are a little bit loose at the moment, but what I'm going to do is get Pete to stand, turn her face the other way, and I'm just going to tighten these up either side. So what I'm going to do is I'm intentionally making an error here, which I'll come back to in a moment. So I'm just tightening these up. You can see these are incredibly long. Okay, so we're getting these nice and tight, and it's just sitting away from the skin. And as I'm doing this, I'm just making adjustments to this popliteal pad, adjusting it either side and just bringing it into position like that. Now, what's really important is that we don't sort of set up the brace in this position. So can you see that we've got double thicknesses of strap in the popliteal region? So if Pete was to flex, you can see there's a lot of bunching, there's a lot of material in behind the knee. So what we want to do is bring these straps back out towards this region and remove this excess of strap. So if you're concerned about trimming them, what's important is that you use these crocodile Velcro sections. I can actually just fold this over, fasten that into position, but you can see we've brought it back way out of the popliteal region. We'd actually perhaps go a little bit shorter on that one, but we'll adjust this one. And at this stage, we've got these sitting flush on the skin in position, and we've normally got 5 to 6 centimeter gap or excess of strap. So if you're just trial fitting these, you can leave those long, but once we're sure we're happy with the strap length, we can just quickly trim these either side and just make adjustments to that. So I've got my scissors handy. I'm just going to quickly trim this either side and then fasten that over the top. I'm going to make a quick adjustment to this one, trim this one, place our crocodile Velcro over the top and fasten that. Now, so what we need to do next is just tension it back up. So Pete, take a seat again. We'll flex the knee, and we can use these smart dosing sections in order to adjust it. So in most individuals, we'd have it at 5. So I'm just going to tighten that to 5. And as we check the strap tension, we straighten the knee, and you can see that I can just check the tension of these straps. So ideally, what we'd want is just about be able to get our finger underneath the strap. It's a hard thing to describe over a visual medium, but you can see we should just about be able to get those straps in tension. And I'm just going to adjust those very slightly. If you've got them too tight, you might find that the patient will say that they're not actually able to fully straighten their legs. So just be aware of that. And because we're using these smart dosing sections just to get it in the correct position, you can make adjustments to it. So I know, because I've got this one at 6, that I need to tighten that strap by that corresponding amount. So about 3 to 4 mil before I finish the fitting at the end. Okay, so we've got a nice good fit here. If we can get Pete to have a stand. We've got that in position, and what we're going to do now is just go over to the mobile camera and have a look at Pete having a walk. Okay, so with this, you can see that as Pete actually walks, we've got the changing of tension in those straps. So when he flexes, the tension reduces in those dynamic force straps, and it's in line with where the position is of the osteoarthritis within the knee. Okay, so we've got a good normal fit of the brace there, and we can then go on to talk about when and how you'd use some of the accessories that we have for the unloader. So these accessories allow you to accommodate and suit the brace to different patient groups. So we've got solutions for patients that have got sensitive skin. We've equally got solutions for patients that need improved suspension if they're highly active, or for example, they're getting any slippage. So we have our brace here exactly as was fitted to Pete. This is a smart dosing version. There is an original version as well, but I'm just going to start first of all by talking through a few of the different parts on the brace. So if we turn this the other way up, you can see that we have a Sensil silicone liner here. This is a standard one as fitted on the smart dosing unloader. We also have a doe skin liner at the top. So the reason for this is we're anchoring this on the calf, holding that in position, and the thigh section is normally a little bit looser, so it allows it just to shift and really anchor in position over the gastroc. The top of the gastroc is really the main area where we can anchor a brace, so it's important that we have those. You can also see that we've got a popliteal pad, and it does come with a spare one of those included in the kit. There are also these half moon shaped pads here, and what these ones are for is actually for if you've got a patient that you're concerned they're going to tamper or undo the straps. You can see that these would come unclipped if they wanted to mess with those. You can actually place those in, and it stops the patient from actually being able to modify the strap configuration. So you just pop that in, and you can see that it prevents that from being removed. Okay. So looking at the different liners that we have, there are different ones for the tibia. There are different ones for the tibia. So looking at the bottom, we have a doe skin liner, exactly the same as the one we have on the thigh. We also have the original Sensil silicone one. And looking at the thigh liners, we also have full Sensil silicone ones as well. So if that's something that you wanted, you can actually replace these liners with those. So what I'm going to do first of all is talk about some of the different options if you're getting migration. So starting at the top with the AMS system wrap or anti-migration system wrap. So this one actually replaces the tibial liner. So as I remove the tibial liner here, I can replace that with the AMS wrap. So you can see that this is a very similar shape to that, but it incorporates a gastroc strap. So that wraps round and then fastens over the top of the gastroc. So I'm placing that back round into position exactly as I would have before, and you can see that this fastens around and holds it into position. So I'm quickly going to fit that to Pete. Okay. So you can see when you actually come to fit this one, we're placing this onto the leg, starting with the leg straight. Okay. Bringing this into position exactly the same as we would before, hinge in line with the kneecap, halfway between the front and the back of the knee. And we're just fastening this gastroc strap as part of the AMS wrap either side. So you can see if I hold these out of the way, and if Pete was to stand up, you can see that it fully anchors the whole brace in position and keeps it there. So it just means we're anchoring on top of the calf in order to maintain suspension. Can be really useful for patients of high activity level or if they're getting quite a lot of sweating. Okay, and once we've anchored that, we just continue to fit it in our normal way, fastening blue on top of that little shelf, fastening it into position, bend the knee, clip that in, and we're then good to go. So you can see it fits in exactly the same way and fits underneath the brace. Okay, from there we're going to go back to the table and talk about the gastroc strap. So with this, there's an extra kit that utilizes the frame in order to add a gastroc strap. So if we're wanting to use one of the doe skin liners like these, we need to add an alternative method of suspension. So with that, we bring our brace in, we remove our liner. So in this case, we had the AMS wrap in there, and we can place in our doeskin tibial liner. So this one fits into position either side, attaches in, and you can now see that we've got dual doeskin on both the thigh and on the tibial section as well. So whenever we do this, we need to prepare an alternative method of suspension. So the gastroc strap actually has a connection here. So can you see that? And this utilizes the same twist fit technology that we use on the Velcro connections. So if I remove one of these Velcro connections on from the frame, if I can, there we go. So you can see with the Velcro connections, they don't have any adhesive on them. They mechanically attach into the frame like that either side. So we place that in, and we can use any of these vents either side of the frame. Place that through, twist fit, and it will just attach into position. This will then come round to the other side, and then we then have this small button which connects in, and again you can choose where you would like this. This brings round and then clips into position. The patient has a finger loop in order to attach this. So this is size adjustable. We've already trimmed this one to fit in this case. And we also have a pad that we can add to this. So there's either a Sensil one or there's a doeskin one. So in this case, I'm going to use the doeskin one, place that into position just so that we can fasten that. Okay, so we're going to bring this round and then fit this on Pete. Okay, we're starting with a straight leg, and we're placing this onto the leg like that. Strap into position, bringing this one round, and then clipping that one into position. So we're using that finger loop, and if we get Pete to stand, bring this one round, you can see that we've anchored it into position. I need to make a small adjustment to my gastroc strap. That's a little bit out of position there, but you can see that that's holding that in position there. So we're getting another method of suspension, and we then fit the brace exactly as we would have done before. Now, one of the last accessories we need to talk you through, just do the last few steps with this, is the sleeve. So we're going to go back over to the table and just talk you through the sleeve. There are different sizes of these according to the size of unloader that you use. So these are sized to be exactly the same, similar color as we have with the unloader, and it's a lycra-based material. It does have a small section of silicone at the top. This has this protective covering on that. So we're now going to take this over to Pete and then begin to fit the brace with this sleeve underneath. So the useful thing for the sleeve is it means it can control soft tissue. So if your patient's got a lot of excessive tissue, sort of muffin top sort of situation over the straps, it can control that. And also it's a way of protecting the skin from any shearing forces from the strap. We're going to go over and fit this. So I'm going to give this sleeve to Pete. He's going to place it over his leg, and you can see he folded the silicone over before he actually brings it up nice and high, folds the silicone over at the top, and that helps to maintain suspension. And when we come to fit the brace, remember that whenever you're using the sleeve, it's important to add an alternative method of suspension. So in this case, we're using the gastroc strap, bringing that one into position and clicking it there. Okay, so it's important to think about a few other sort of different issues that we might come up with. So very occasionally you can end up with sort of redness in this area. That's a common area that we can end up with an area of redness there. So what's really important is that we're checking the hinge position. So what is very common when we've got an area of redness here is actually that the brace has been fitted a little bit too low. So I'm exaggerating, but you can see my hinge position is here, the patella is here. So what happens is as they flex and extend, you will get sort of slight wiggling and surface movement of the frame. So it's really important that we double check we've got that frame in the correct position, correct position AP. Another area can be the tibial crest along the front there. So there's a couple of things to check with this, and that's normally to do with the hyperextension that the patient has. So very occasionally, the patient has got higher levels of hyperextension. You can see that the brace is designed to stop at 0. So it's sometimes necessary to adjust the stop in here just to allow a little bit of hyperextension. And if in those situations you need to do that, just contact us and we can send you an extra stop that allows a degree of hyperextension and just allows it to conform to that shape. One of the other things you can also do is apply a small piece of padding built in between, just add padding in between the frame and the liner and just pad either side of the tibia. So that gives you an option to offload that area. Okay, so it just remains to say thank you. Thank you for joining us this evening. If you've got any sort of further questions, our contact details are on there, and you can contact customer care or either one of us with regards to any questions. Thanks very much for joining us, and we'll let you know about any further webinars that we have running in the future. Thanks very much.